growing weary of running from room to room, practicing one-tooth insurance-driven dentistry? Then stay tuned for the latest episode of the Lionhearted, where Dr. Stephen Rasner will hand you the blueprint for what many call the gold standard of general practice dentistry.
Hi everyone, Dr. Steve Rasner and the Lionhearted Dentist Podcast back once again. Thanks for y'all joining me each and every week. My podcast does continue to grow, and it is fulfilling for me, and hence I will keep doing these until I don't feel that. So thanks for all of you from all different parts of the globe. It feels pretty cool. Last week I talked about a couple things. I just want to make sure in case you missed it or in case you forgot about it. I did a podcast, which is not what it is about this week. This week is back to my favorite subject in the world because it's the most impact subject you could talk about in your practice daily, and that's case acceptance. Case acceptance. And we're going to go back to that, and I'm going to tell you why, in case you haven't thought about it. It is so daunting. There's good reasons for it. And I'm also going to give you two case presentation stories from this week that were surprising to some degree, ended up pretty good, unbelievably challenging to get those people to understand and want to proceed with better oral health options, which cost a lot more. But last week I talked about the cost of you doing nothing. I remember saying it, whether you were a late D student, dental school student, getting ready to make your career choice, very much speaking to the associates in the industry. There's such a big chunk of us that are presently finding your roots, man. You're working in one office or several offices. And then those of you also that have made the leap into private practice, you're in your own practice now. Maybe you're doing both. I'm sure many of you are. You're an associate somewhere, filling in the gaps of revenue as you get your practice started. And I asked you to ask yourself to not waste time, to really take the time to self-examine, and warned you of the cost of doing nothing, because how frightening it is how quickly time moves. And I want you to take advantage of this amazing opportunity that we both have in dentistry. And I know you know when I talk to you like this that it's completely authentic. Why else would I motivate you to self-examine? Because it's easy to get caught up in a comfortable space for you that's not really what you want, but it's comfortable. So please go back and look at that. I don't want to beat it all up again this week. But if you don't take the time to say, am I really happy? Do I like where I live? I mean it. In the beginning, the first couple years, you may have to make sacrifices and not be in your ultimate spot geographically in the world to get another goal down, like early postgraduate experience, which we all need. Certainly if you're in a GPR or postgrad residency. And in a sense, you know this is true, that a lot of the associateships we take are the postgrad residency for many of us, right? So you may be stuck in a place that you don't really want to end up with, but you're learning how to do, I hope, better quality care, faster, efficient quality care. But you're certainly, if you're an associate, not maximizing and having total liberty to maximize the potential that you have up there in your brain and your hands. So that's what I mean. And just to reflect back on earlier podcast, I've been a big advocate of you not overspending money in the first 10 years out of dental school. And I told you that the common thread with almost every successful dentist I've ever met is someone that took that path. I did not take that path. I did overspend. And it's a much harder path to come back from. And many don't. Most don't. Don't think there's not a lot of dentists that go bankrupt. They can't resist the urge, and I get it, because I was almost there, to buy, oh my God, finally get a nice car, finally get a nice residence. And a lot of us make decisions based on, well, I can afford that in my monthly budget, right? A new car is only $760. Or even a new house is only $3,200. And hell, you're taking in blank and blank, right? I mean, I did that horrible math. And what happens is you end up often with paying huge bank debt service. And depending on your credit scores, which can often be not superb early in our careers, you waste hundreds of thousands, if not more, dollars in a career. So that's why I've been a big advocate of you going light with debt and living under your means. I know that's not sexy. But the one area that I would borrow from, without a doubt, and I don't know who else talks to you like this, maybe there's many, would be CE. Investing in yourself is a very worthy, noble cause, and will never let you down. How could it? So, yes. Do you have a skill set yet? Are you working on a skill set, even if you're an associate, that makes you so marketable and will make you even more marketable once you have your own practice? And of course, I've pushed you for years now with the skill set of oral sedation. Let's talk for a minute about what I want to speak about this podcast, and it's why case presentation is so daunting. It never doesn't fall out of my mind of why it is such a part of our everyday skill set that requires constant monitoring. You can never take for granted, pardon the expression, when you're on stage and you walk into that operatory for the first time and are meeting your new potential patient. And the reason, without a doubt, there's several reasons, it is so daunting, is because the majority of the profession does not follow a comprehensive care approach, which makes you look perhaps aggressive or scary or thorough or, in their mind, expensive to the everyday consumer. And that's just the truth. Think about this for a minute. The last time any of you have gone to an inpatient, outpatient hospital center, it was pretty consistent, right? You went through paperwork. You knew that you were going to get a full exam and a lot of parameters that were almost ancillary, a lot of things, a lot of input information they had to take, a lot of examination, part of the examination process that wasn't directly related, at least in your mind, to what you went there for. And that's almost a given in any hospital we go to because consumers accept that. And I'm here to tell you that the mindset that some of you have been following, and I know there's many of you, that a patient calls you up and they have a specific chief complaint. They broke a tooth. They have recent pain. Even they don't like their smile. Lots of us believe that we should address that issue first, for lack of a better word, win the patient over, bring them back. That's the worst thing you could do. There's some of us that think that we have to prophy them the very first time they come to us. And in my practice, in a Lionhearted practice, that's only going to be possible, pardon me, if that's possible, meaning they have a beautiful periodontal condition already. They don't have the need for a lot of conversation about the rest of their dentition. You could easily glide through the 5 areas that I ask you to examine in a comprehensive exam. Sure, there's people like that. Not many. But here's the problem that most of us face. So that's not a Lionhearted approach. Doing one-tooth dentistry, trying to win the patient over because you solved the problem that they came to you for on that day. I understand your reasoning. It's just wrong. It's not a way to build a solid practice. And remember, everything I'm telling you are things that I have learned from doing and realized that there is a better alternative. That's why I talk like this. So, no matter what the patient comes for in our office, unless it's a blown out, swollen, almost febrile patient, which is almost never in my practice anymore. It was early in my years. Yeah, that patient, I would script. I wouldn't even begin. I would try to diagnose what was going on with minimal x-ray exam. I just can't remember. I cannot even give you one example right now when that last happened. So I think it's because my practice does not attract that kind of patient. Emergency patients that I just described, that is almost always their history. Their mouth blows up, they call one of us, they get medicated, maybe they get a tooth extracted, and then they wait another 5 years till the next one. Who the heck wants a practice or a legacy of patients like that anyway? I mean, how fulfilling can that be? Listen, come on, man. You can't be everything to everyone. If some of you enjoy emergency care like that, then good for you. That's not what I signed on for. And it certainly doesn't follow the philosophy of these podcasts. So the problems you have is that, number one, think about this for a moment. You have a patient in your community who has chosen to come to you. And they've gone to other dentists their whole life. This happened to me last week. And there's a good chance, I can't give you a real percentage, but I'm sure it's over 50, that the doctor that they went to does not embrace a comprehensive care approach. So what's that mean? It means that the patient that came to you has probably never spent significant money. That means the patient that came to you really likes that other doctor already. And the only reason he's with you is that other doctor probably doesn't practice anymore. And I'm talking often about good old Dr. Joe. I have mentioned him many times in my podcast. He's the doc that watches everything, places 5-6 surface restorations on a tooth, will patch up this and that, occasionally pull a tooth or refer you to have a tooth removed. You never spend any money with them as a patient. You really, really like him. You're not in his office very long, and you're okay with the way your mouth is, because the second problem that we face, besides the fact that most of our own colleagues don't embrace comprehensive care, let's just break down comprehensive care. I'm asking you on many, many podcasts to go back and look at my examination process, which looks at 5 arenas of the mouth, no matter why they came to us. We look at always first the periodontium and the health of that, because it's the number one thing wrong. Stay with me. We look at every single tooth. I don't treat every single tooth if there's something wrong, but I will certainly be examining that with this patient in a box on the computer screen as I go through each tooth. 3, they're muscles and joints. I don't spend an enormous of time with that for 2 reasons. I don't hesitate to refer out difficult or challenging muscle patients. It's just not my thing at this stage of my career. That's one reason. And another reason is a lot of patients that present to me over the years don't seem to have that as a chief complaint, or any complaint, even when they're examined and palpated, etc. The 4th thing I look at is their missing teeth, and the 5th thing I look at is their aesthetics, and that is pretty much it. And I'm saying to you, that's not the case in most other offices. But if you do that, what I just said, it is really hard to find a patient that doesn't have some oral health parameters that are lacking in any one of those 5 arenas. And guess what? Most of the time, it's asymptomatic. It doesn't hurt. So let me just take a left turn for a minute. I had a patient who knew me, who had gone to good old Dr. Joe in the neighboring town. I knew it when he called. He knew me. So there's a bond. This guy knew me. Remember, I'm practicing in an area that I grew up in. So this guy knew of me my whole life. He was a little older than me, but he went to high school when I was in high school. So maybe I was 3 years behind him. And it was typically what I see, and disappointing. First of all, I went to a doctor who was very capable. Sad side note, that doctor had passed, which is why he was in my office. But I knew it was going to be a challenge. And he came to me because, quote unquote, my teeth are falling apart. Well, he said it, and he couldn't have been more correct. And sure enough, multiple large restorations that were falling out, recurrent decay. I mean, there would be zero discussion by any of you, zero debate that this patient, if they cared, needed significant restorative work. And I am talking removing old restorations, cleaning gook out, filling them up with Bill Strupp type of cores, prepping them for full coverage crowns. As a side note, he still had reasonable occlusion. He didn't have many missing teeth. His perio was in reason. But we're talking about somewhere between 8 and 12 full covered restorations. I mean, this was a typical patient you and I come across. He had one crown on number 7 and one crown on number 11 and maybe one on number 14. These were teeth that even good old Dr. Joe couldn't fill. You know, poorly done root canals, asymptomatic. I mean, on and on and on. And I did not win that case. When I get a case like that, it's very challenging. Many of you get them, particularly when you buy an older dentist practice that was a good old Dr. Joe. Look, I'm not indicting the whole profession. Obviously, there are more now than ever phenomenal colleagues of ours doing it right. I get that. But I'm just calling it the way it is. I'm not pulling punches here. I've been doing this too long. I see what I see. So the first daunting part is that it makes you look aggressive even when you try not to be. And I deliberately try not to be. I tell the patient, I'm going to go in and I'm going to be as conservative as I can be with you today. As long as that will work. And I'm very upfront. With a patient like I just discussed, I'll say, look, I can see that you haven't had any significant dentistry in a long time. You have a couple crowns in your mouth. But you have very, very heavy fillings, restorations, whatever term I use. And you came to me because even you noticed that some of these are out. And so what would happen if I was ultra conservative with you and I tried to fill them again and then they're out? Because the more a dentist tries to fill a tooth on the fourth time and fifth time, there's even less of a chance that I'll hold. So then you'll pay me and come back, whether it's 6 months or 2 years, and it's going to go fast, and now you'll need to reinvest. You might ask me 2 years from now, why didn't you tell me then what I needed? Which is exactly what I'm doing. I mean, I do not lecture to them. I try my best to reason. But that patient I described, the good old Dr. Joe patient, is a mega challenge. Which brings me to my next one. So again, the reasons that this requires such diligence by you, to have all these conversations in your head, where you're going to go with the conversations, not always the same place. The good old Dr. Joe patient is a very challenging one, where you have to walk, lightly and not criticize and throw the other guy under the bus because your patient liked it. And then you have to talk about the value of doing it right. And do you really care about your teeth? Because this is what it's going to require if you do. And I know this is different for you. And I know it's going to be more of an investment for you. And I am not here, sir, trying to sell you. I am just talking to you. I mean, that is my attitude. And if you want more of that, I'm talking to you guys. I have written text on what I'm saying to you right now. But I want to tell you about 2 cases that came out nicely with 2 different approaches this week. One, the first guy, you'll love this. This was my first new patient. And by the way, I don't get a ton of new patients. I wish I did. But in my part of the state and the part of the United States I'm in, I've been there 40 years. They know I'm fee for service, which means they have to go out of network. They think I'm higher priced than I am because I have a comprehensive care approach. So it does cost more if you look at more things that you should be looking at to decide a patient's care, right? That all makes sense. That's a Lionhearted principle. It's not how much can we make this be? It's do what we were trained to do, right? Goodness. Well, the first patient, my hygienist comes in on, this is last Monday, and says, he literally said to me, he wants 1-tooth dentistry. That's what before I even walked in the room. He allowed us to take a full set of x-rays. He allowed her to chart him. He'd been to me 25 years ago. That's what I mean when I tell you about creating this giant nucleus of patients, leaving a good taste in their mouth, because you never know when they'll return. And it was 25 years for this guy. I was told by my hygienist before I walked in, and the tooth he wanted fixed was number 9, a 20-year-old crown that had chipped. That's it. So I, didn't put me in the greatest mood to walk into that to start my Monday. And I walked in the room and I said, welcome back. And he said some nice things. He said, that work you did 25 years ago still feels great. And I said, listen, since I've seen you, I think you remember then that I was 100% all in to my profession, and that never changed. And I probably know more now than I ever did. So let me say this. I know you. I hit the nail on the head. Now I'm looking at a guy. This is a factory worker. Actually, I think he drove a bus for school now. He was a factory worker and now in some kind of semi-retirement, driving a bus, extra money, spare time. So that's his deal. Very, very blue-collar type of patient. Certainly wasn't seeking a smile makeover. And I proceeded to examine him in the areas that I told you about. And he had a couple missing teeth, maybe one molar on each side. Decent perio, but needed scaling root planing. But had 3 to 4 teeth, which he had no interest in 5 minutes prior to me getting there, that needed full coverage. They were actually out of occlusion. So when I got to the occlusal part of my exam, it was easy for me to communicate and convey to him. I said, listen, I want to explain something to you, and I hope you can tell that I am totally sincere with this. I want you to put this mirror in your hand. That's literally what I do, guys. I have an intraoral camera in every room. Maybe that's a better way for you. I put a mirror in his hand. I said, I want you to look at this side of your mouth. I know it doesn't hurt or bother you, but do you see how these teeth are broken down? They don't even hit the opposing tooth. So what's happening with you is you don't have support in the back of your mouth, and all your forces are coming forward, which is exactly why you cracked your tooth. I said, if I came in here and really did one tooth dentistry on you, which you've asked, and it's a year from now, less, and you chip it again, and then I tell you what I'm telling you now, wouldn't you be put off a little? Because I would be. Look, you don't have to do anything except hear why I would do what I would do. And he turned out to be, I did not make this guy's mouth gorgeous. I'm going to recrown the one tooth, try to match the adjacent tooth, which I hate to do. I don't think this gentleman will care if it's not magazine printable. But he's going to get full coverage. He's going to get restorative where I could do restorative. Trust me, this patient was not in pain. He was asymptomatic from top to bottom. He was only there because he chipped his front tooth. And I assure you that was a moderate-sized treatment plan from a gentleman that had no intention. And I also assure you, he believes in me, and he understands that this was the right approach to his mouth. And then the last patient I want to talk about is always one that's a little challenging. He's 82. So picture this. 82-year-old, adorable man with his wife, who I had treated successfully 5 years ago with over implant, a denture retained by implants, removable. And he even had broken English. He looked like he just still worked on the farm, so to speak. He had a full upper denture and a lower denture of 3 years. So here's my approach to those guys. I said, listen. Now I knew that he knew that I had done implant work on his wife. But that was 5 years ago when he was 77. I said, let me tell you my approach. Let me first talk to you about dentures and why they are so unsuccessful, particularly the lower denture. And I talk just like that. This is after I say hello and make them feel comfortable. A lot of times I will say to a patient, maybe not this one, so I often like to acknowledge how nerve-wracking it is to meet a new dentist because you're so on edge. I'll say, even though I have great solutions, I'll say that to a patient. I'll say, let me first acknowledge that I know it's a new thing. I'm the new dentist today to you, even though I've been doing this 40 years. You could say, even though I've been doing this many years. And I know it's, hard for you to accept and trust and believe another new face. And if you give me a few minutes, I think you're going to really like what I have to say. So let's talk for a minute. And I'll give them my background of something that's relevant to why they're there. About my fervent investment in CE and how it relates to him. And I'll tell you what I did tell him. I said, I'm from this area. And when I came back here after dental school, I got a lot of appointments because everybody knew me. And one of the appointments was I was a Cumberland County senior dentist. You know what that meant? That's what I told him. It meant that I went from doing 2 dentures in dental school to taking care of 30 people at one time with dentures. And you know what happened? I didn't know enough. And I took every course there I could find to do the best denture I could. I came to the conclusion early on that lower dentures are not a good solution for most people. There's always somebody that you can make something for, they'll accept it. But in general, it's a problem. And I have models, as you've heard me explain to you. By the way, I duplicated them to sell you if you ever want them. Not literally for what it costs me. So if some of you don't want to go through the motions, and it's a few $100, I got a beautiful upper and lower model on an articulator, which you'll get, with a denture, upper and lower, that you can flip off like I do to a patient that's wearing or never wore a denture so they know what they're going to get. And they can look at the model that it's made on and understand why it's a challenge, because you can see it. Even if you're a consumer, you can see it. So I went through that with him so he understood why it was a struggle. Remember, he had only been in a lower for about 4 years. So I said, look, here's what I know about 80-year-olds. Nothing. You're all different. There's 80-year-olds that are in government, that lead different sectors of the United States and other countries. There are 60-year-olds that come in here with assisted air breathing in their nose with a carting around a tank that look like they have 1 foot in the grave. Here's what I know, sir. I have no right to look at a patient's age and determine what is good or not good enough for him based on his age. That is only your decision. But here's what I'm going to do. I'm going to tell you what I would do if I think you're a candidate. And I had already known his medical history. And he had sufficient bone. I could tell I had an x-ray already before I walked in, because I knew he was coming in with a loose denture. So there's already a CBCT taken. And I wanted to see his condition of his mouth, his attached gingiva, and he was a good candidate. So I said to him, look, I'm going to recommend for you exactly what I did for your wife. And in his case, it was a little unusual because I almost always connect my mandibular retained implant dentures with a bar. He had very sufficient attached gingiva and a decent ridge, and I thought he could get away with zest locators, and I treatment planned him for that. And at the end, I said, listen, I don't want you to do something that's going to pressure you weekly or monthly financially. I know your wife had something done 5 years ago. I say these things, guys, I swear. I said, I don't know how long you'll be here. I don't know how long I'm going to be here. But this I do know. 3 times a day or so when you eat, when I'm finished with you, you will eat significantly better. And that part of your life will be incredibly more enjoyable than it is now. If that's worth it for you and this works in your world, then do it. And if it doesn't, don't. That's how I talk. Now, maybe that's not profound. It doesn't seem profound to me to say this to you. But those 2 cases were accepted. And it was a good day. And it was part of another good week in a Lionhearted office home center. I love talking to you guys. So many of you give me feedback and make me feel that this is helping you. Again, let's close with, I'm considering an oral sedation course. And I remember a year ago I talked about, maybe I'd put out there 6 months to give us plenty of time to have a live Lionhearted 2-day or 1-day seminar where we can beat all these subjects to death. I could bring in a top guest speaker if you like in addition. Try to make it as affordable as we can. Give me feedback on that if you like that. I hope this is helping. I hope you're staying strong. We're in mid-July, going into the second half. Don't waste time. Let's make this count. See you next week on The Lionhearted.